If anyone's familiar with Roger's work, it's really exciting and groundbreaking stuff. So to have that transposed against Professor Mary Foley's presentation, which will follow, someone who's really been leading at the coalface to try and implement some of these serendipitous ideas, is going to be really quite a treat for us today. So with that, I'm going to hand over to Roger, and thank you very much. Silent or off. Thank you.
Despite my best attempts, we're still spread out quite a lot. But that's okay, I can deal with that. So I'm going to talk about some work that I've been involved in the last decade at the Canterbury District Health Board in Christchurch across the pond. And I want to start by prefacing the context for this. So this is a slide that one of the researchers from the King's Fund now uses around the world. The King's Fund is one of the leading healthcare think tanks globally. And this is a slide that they put up to illustrate who are the top performing healthcare organisations in the world. This is a slide from a presentation they gave in November, actually. So you can see there's not many that they rate independently as top performers, but Canterbury is up there. And I'm going to talk about a few of the key things that have driven that transformation program to get Canterbury where it is today. So the first thing amongst these is something which I'm very, very keen on, is actually understanding how much risk to take, when to take it, and how far to push the boundaries. So this is David Mates. He's the chief exec of the CDHB at the moment. What's interesting about this is his appetite for risk. Not only his appetite, but the appetite of the chief exec who started this whole program off back in 2007, a guy called Gordon Davies. And when I was originally pitching one of the first pieces of work on this transformation program to Gordon, I spent literally days briefing him. And the night before we kicked things off, he said to me how he was feeling, and he described it as equal amounts of terror and excitement, which I thought was a pretty good place to be. In the debriefing session at the end of that first set of work, I sat down with Gordon and I said, how do you think it went? And he said, to be honest, Roger, I had no idea what you're talking about at the start, but I thought it was worth the risk. The next big chunk of work we did, which was also quite groundbreaking 2 years later with a different chief exec, David. Same process happened, so I explained to him carefully how we're going to do this, the building blocks, the theories, how it was going to play out. You're welcome to sit at the back, by the way, I don't mind anymore. And I could tell David was nodding and smiling in the right places, but in his eyes he just didn't quite understand. And 3 days after we started, when it became clear we had a runaway hit, he came to me and said, I had no idea what you're talking about, I thought it was worth the risk. Right, almost word for word what Gordon said. Small amounts of risk, trust and big outcomes. Next thing that's important is what I call idea arbitrage, or to put it other ways, learning from sectors and industries you would never normally look at. So as part of the first piece of work we did, what we did was learn from organisations such as Air New Zealand, from advertising agencies and from hotel industry. So to give an example, this guy is the food and beverage manager for one of the top hotels in New Zealand, consistently wins things like Condé Nast Gold Awards. He was talking about a whole range of insights, not least of which is they train their gardeners with the same level of customer service as their GM. The rationale for that being that when a guest leaves the hotel and walks out and decides which way to turn off the street, the gardener could be the last staff member they see before making a decision. So little insights all the way through from different industries have given rise to different thinking within this health system that people would otherwise not normally get, because people get stuck in paradigms and they find it very hard to break free of that. I could talk to you for hours about how that works. The other thing is really, really important is this. So thinking beyond cycles is absolutely critical, and we heard some of that this morning. I thought one of the key takeaways from the complexity session was the need to think long term. It's the only way you'll break free of some of this nowism that goes on in public service. So what we did at CDHB, we did a whole bunch of stuff around developing scenarios where healthcare might go in 2020. We used a graphical artist to mock these up, status quo versus change system. We spent a lot of time talking to clinicians about how this would work. We worked out timeframes, costings, etc. We use these scenarios to take the board through and expose them to some of these in an experiential fashion. That's a really key thing, is how do you communicate, what's the narrative you build around long-term thinking. We did things like give board members lanyards to illustrate either patient point of view or a clinician point of view. And they had these lanyards as they're going through some of the scenarios we developed. So really experiential exposure to some of this stuff in depth, rather than just giving out black and white documents. That never works, especially if you put bold and underline and that sort of stuff in there. So dead method for communication. This stuff resonates with people very strongly. At the end of the day, what you're really trying to do is create an empowered workforce. And what you find is that you need to create permission from the top to allow empowerment at the front line. So a big piece of the program that Canterbury has embarked on is how do you get tens of thousands of people, or 18,000 in Canterbury's case, to understand that transformation starts with them, not with somebody else in management, and they can't always blame them for what's going on. And one of the things we recognised very early on is that when you talk about visions for systems and large-scale change, there is a desire for people to participate in it, but they don't feel like they're able to. So very early on, we developed things called permission cards. This is one of the first ones we developed. It's not that big, of course. It's wallet size, laminated. From the very first program we ran, where we had 80 people involved, we laminated these, got them signed by the then chief exec, gave them out, people left the program, and the reaction was quite extraordinary. So some people, upon receiving these and getting a handshake from the chief exec, actually started crying, right, because they felt so empowered and overwhelmed that they'd actually been given permission to make stuff change. The then chief exec, Gordon Davies, tells this great story of 6 months after handing one of these cards out. He was doing a tour of a local rural hospital, and this charge nurse came rushing up to him and said, "I did this and this and this and this," and she pulled a card out and said, "Because you told me I could." And he sort of went, "Oh, wow, okay." But it turns out the change cost very little. It had a big impact, and she felt empowered, and so did all of her staff, and they knew the alignment of direction to take. It wasn't herding cats, the classic innovation problem. So this is very, very important, and now permission cards have become one of the key things that people get in the DHB when they go through certain programs. They have permission to go out and make change happen, as opposed to sitting back and feeling disempowered. The key thing is, how do you build the narrative up, and how do you get alignment at scale across thousands of people to make sure you're not giving permission for them to sort of do the herding cats challenge. Once you have empowerment going in the organisation, you can start to do really interesting things. So I can talk to you for hours about some of those interesting things. I'm going to talk to you about one project, which is a direct result of that empowerment piece. After the Canterbury earthquakes, there was a need to rebuild about $1 billion worth of infrastructure, so complete reconfiguration of the hospital. One of the things we highlighted very early on was that we didn't want to have a situation where you built a building and had to retrofit it to make it suitable for purpose at the cost of more taxpayer funds. So we decided that architects delivering plans on paper to users of facilities wasn't going to be enough. So what we did is we took over a 10,000 square metre warehouse, converted it into a design lab, and brought people through, starting with mocking up spaces by putting masking tape on the floor. So this is a treatment room, this is how big it is, put a bed in there, does that work? Try that a few times. And then you use light cardboard walls to start mocking up the space, put more and more things in there, increase the level of reality and sophistication, till finally you get to what's called a high fidelity mock-up, where you can bring architects in and say, actually this is what works for users and for floor space and for a whole bunch of variables. You know this sort of stuff works because I was in the design lab once, about 3 years ago, when a group of orderlies were in there testing a patient room for a spinal roll. So they had a mock patient in, they had a room all mocked up with cardboard, and they put this patient in, did a spinal roll, and stood back and clapped and cheered afterwards because it worked. So you have orderlies designing storerooms, you have clinicians designing hospital work areas, designing patient rooms, etc. This is what the process actually looks like. So sort of in the top left-hand corner, really, really basic mock-ups. You can start to look at different ways of developing this. So we tried a whole bunch of different methods and ended up going away from square rooms into herringbone style rooms. You can see the bottom right-hand corner, there's a really basic mock-up, people lying on cardboard boxes and mocked up beds just to see how it works from different points of view. And then when you start going up a level of authenticity and sophistication, you can see how the prototypes go from low fidelity to high fidelity. The key thing about this story is if you tried that without having a whole program of transformation, permission, and sponsorship in place, it wouldn't happen. Right? There's no authenticity involved in that process. But now the design lab is a place where people go to innovate, to try different things, and it's one of the most popular buildings in the whole area. It's 10,000 square metres of pure innovation. So I work with clients across public and private sector. I've worked with a whole bunch of different public sector organisations in different areas and different spheres with varying degrees of success. And one of the key observations that I've come away from is the need to do this. So typically at chief exec level or tier 2 level, you have enough capability. When you start going down to third and fourth and fifth tier, it starts evaporating very, very quickly. Right, so I see this in New Zealand civil service, I see this around the world, with the exception of Singapore. When you go to Singapore, it works very, very well. In New Zealand, Australia, UK, not so well. So the answer in the Canterbury DHB was to have programs of education running alongside some of these big transformation pieces. There's a program called Accelerate, which is all about lean thinking. Started off in 2007. Basically, cohorts of people go through this program. It's intensive, in depth. And now, I think there are about 1,000 people who have been through this program over the last decade or so. And it creates a fundamental change in how things are designed and how people work and how people measure quality outcomes. There's a whole bunch of lean thinking process that goes into it. This is one of the key artifacts they use for it, around valuing patients' time. Other programs around how to create large-scale change, how to understand systems, how to be change agents are critical to that. But I come back again to this, right? You need to build capability in the organisation. And the CDHB is quite a standout example in this case because the Auditor General came through a whole bunch of organisations in New Zealand last year, and the CDHB ranked in one of the top few percentage-wise. I think you might have a number on that, I can't remember what the number was, but very, very high performing, one of the top 4 or 5, I think, performing public sector organisations in the country. That, combined with the fact that it's stripping out wastage in the system, so in 4 years, it stripped out 1.5 million days of patient waiting time from the system in 4 treatment areas alone. So if you think about how much time that is worth to patients and how much that costs the system, you start to see some of the magnitude of the scale of changes that are going on. So early on, the program was a bit risky because you didn't have any data about it. As you started getting more and more wins, you could build more credibility and start picking up transformation pace more and more. But unless you build capability, then actually you're not going to get anywhere. So this is the chance where I get to take a breath. You can start thinking of tricky questions to ask me after Mary's talked. Thank you.